I want to begin today by acknowledging that we are privileged to be doing this work today on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And my name is Fred Popowich, and I'm the Scientific Director of SFU's Big Data Initiative. And thank you very much all for squeezing into this area there. I checked it out ahead of time, and yes, we can see from the far corners there, and I'll try to make sure that we speak to everybody here. On behalf of Simon Fraser University, I have the pleasure of welcoming you to our Fall 2019 Data Visionaries series. It's a series dedicated to bringing together pioneers in the field who are shaping and reshaping the world we live in. I encourage you today to join in online to the conversation over Twitter using the hashtags SFU and the hashtag Data Visionaries. And if you're doing that online, make sure you have your phone on silent or vibrate mode. I just checked mine, and yeah, definitely it's on silent mode there. So this way, and feel free to take your pictures, make your comments, and actually that way you can start the conversation early. Now, in the context of tonight, as healthcare analytics enable industry to move towards patient-centered care, there's critical conversations around balancing privacy and innovation. Healthcare analytics empowers providers to make data-driven decisions that reduce healthcare costs and improve patient outcomes. But at what cost? And I'm not the expert on this, so that's why I have the pleasure of introducing the experts tonight. So I'm first going to call up to the stage here Ohad Arazi. Ohad, if you want to join us up here. Ohad is Chief Strategy Officer and Vice President of TELUS Health. His mandate is to advance TELUS's health strategy, establish collaborative services across the company's diverse solutions, and work with clients to use technology to achieve better health outcomes. He holds responsibility for TELUS Health's innovation practice, bringing disruptive thinking and an outside-in perspective to that organization. He also leads the Provider Solutions Business Unit, responsible for growing and establishing new products and solutions that will engage physicians and patients within Canada's health ecosystem. Thanks very much, Ohad, for joining us.
Thank you.
Next, I'm pleased to introduce my colleague who is a professor at Simon Fraser University in Bioinformatics and Genomics, Fiona Brinkman. Fiona, care to join us on stage here? Dr. Brinkman has been leading large consortiums to tackle the global health threats posed by infectious and inflammatory diseases and antibiotic resistance. Her research and widely used open source computational tools have led to fundamental insights into how microbes evolve and are enabling health agencies to implement more sustainable control of infectious diseases and to preserve microbiota essential for human and environmental health. She is on the board of directors for Genome Canada and chairs the scientific advisory board for the European Nucleotide Archive. So thanks very much, Fiona, for joining us tonight.
Thank you.
And I'm finally pleased to introduce my colleague from Toronto, Mohammed Mamdani, who's the founding director of the Lika Shing Knowledge Institute of St. Mike's Hospital. The institute that Mohammed works at bridges advanced analytics, including machine learning, with clinical and management decision-making to improve patient outcomes and hospital efficiency. He is also a professor at the University of Toronto and has published over 450 studies in lead peer-reviewed medical journals. Thank you very much, Mohammed, for joining us. So just to give you an idea how we're going to structure things tonight, I'm going to be asking each of our panelists for a brief introduction. I have my timer here, so I've given them 5 minutes where they can sort of have a minute to talk about themselves and sort of maybe 4 minutes to sort of set the context of, 4 minutes is enough to talk about the future of healthcare, data, analytics, and empowerment and everything, right? Yeah, that's trivial. So after their opening statements, we're going to go into a panel discussion. I'm going to break it into, initially planning on breaking it into 2 parts, and to get the discussion going, I have some prepared questions, but full disclosure, we discussed the questions ahead of time, so they know what they're getting for those questions. What they don't know what they're getting is when we open it up to questions from the audience, which we'll do afterwards. And when we do open it up, we will have a couple of microphones for passing around, so I will be asking for people to have questions. Raise your hand. When I acknowledge you, I will say 1, 2, 3, and so on, so that our people with the mics will be able to go around and get your questions. Keeping this in mind, this gives you a lot of time to think about your questions, but keep in mind that I can be really nasty too, because I've been a professor for a long time, and I run a tight ship in the classroom. So I want you to keep your questions short and concise, and it can't be what's on the final exam, just to let you know that about that. And also no long preambles. We're not allowed, I've seen too many legal contracts and the whereases and the context like that, it just can go on forever. So that'll be my rule. So, and if you have multi-part questions, think of what the best question to ask is, okay? So with that, let's get started. So I'm going to, why don't we, start closest to me. So Ohad, why don't you introduce yourself a bit better than I would have done and give a bit of context of what you think about all this stuff.
Super. Thank you, Fred. Thank you all for being here. What an awesome audience. I mean, a bunch of geeks showing up for a talk about healthcare data. I love it. My name is Ohad Arazi, and I'm the Chief Strategy Officer for TELUS Health, and been working in health IT for about 14 years now. Super passionate about the topic of data, and really in particular empowerment as it relates to data in healthcare. In 2016, the Harvard Business Review published a great article about data in healthcare. And in this article, they said, we really think this internet thing, it's going to be big. Now, that was a funny thing to say in 2016. It's even funnier to say today when, the internet and access and networks and access to data is so ubiquitous. And, yet for all of us that work in healthcare, it's only really half funny. It's actually half sad, right? Because this $8 trillion global industry still relies on paper and faxes and clipboards and legacy instances of software that's buried in a hospital basement, your patient record residing on the server of a PC in your clinic, in your physician's office that's running Windows NT. That's the reality. And, healthcare is for a long time has been trying to kind of rebrand itself as consumer-centric and as putting patient-centered healthcare. But I mean, we're so far behind many industries that have really put consumers at the center. And first of all, it starts by actually calling patients consumers and realizing that they're consuming a service, right? Even if they're not paying for it in Canada, they have choice in where, what, and how to consume the service. And actually thinking of healthcare as a consumer industry is going to be a key part of the thesis that I'm going to try to lay out today in the answers to the questions and really to engage on that. And of course, it's a very significant challenge. I mean, this is serious business. It's your right, privacy, security, consent. Those are all very, very critical things as it relates to healthcare data. And yet, other industries have also overcome that challenge, right? I mean, look no further than banking, right? You can take a piece of plastic and put it into a wall almost anywhere in the world and get access to your full banking record. You can transact on your information, right? So I think we have to overcome some of the kind of legacy paternalistic views that we've had systemically about healthcare and consumers and their data. And really establish, one clear fact that the only owner of your healthcare data is you. So we're going to dive deeper into that with some of my thoughts, and looking forward to the conversation.
Great context. Thank you very much. Okay, Fiona, it's time for you to top that. You have your 5 minutes to introduce yourself and to set some context.
Well, it's a real pleasure hearing from you, and I have to say it will be hard to top that, but I can say that I'm a professor at Simon Fraser University with appointments in molecular biology, biochemistry, computing science, and health sciences, and I love taking different ideas from different fields and pulling them together and coming up with new ideas. And really what has blossomed for me is this interest in coming up with more sustainable approaches for infectious disease control. So I definitely come from one corner of healthcare and public health. And basically, one of the ideas is to sort of really be tracking infectious diseases more globally in a way that's not looking at just people, but also people and animals and the environment, pulling all this data together. But what's really become clear is there's some big challenges with that. Because, for example, with weather data, you can just gather all this data together and have fantastic forecasts that have big impacts on us in terms of being able to look out for severe weather events, implement practices to keep people safe, implement practices to reduce damage to economies. Same thing with infectious diseases. You can try to come up with approaches for pulling all this data together, and then you end up with potentially even better impacts, which is you can actually nip it in the bud. You can't nip a hurricane in the bud so easily. Contrary to what's been said, you can't put a atomic bomb in a hurricane, but you can absolutely nip an infectious disease outbreak in the bud more quickly by sharing information. However, there's big privacy concerns, and one of the big problems that we wrestle with is this issue with privacy concerns, appropriate use of data, and what we're finding is there's more of a sort of social science side to how people perceive risk and privacy, and then there's also a need for more sophisticated approaches, better than Windows NT, for handling this data and coming up with better ways for sharing things that will address real privacy concerns. So it's my pleasure to be here, and I look forward to all the questions.
Great, thanks very much, Fiona. Okay, Mohammed, it's over to you, your context.
Great, thank you. It's a pleasure to be here. I'm a clinician by training, but I've also done a couple of other things. So I have a Master of Arts degree in all things in economics and econometric theory. But then I also have a master's degree in biostatistics and epidemiology. And then at that point I was so broke I had to get a job. So I avoided reality for as long as possible, moved to Toronto, and started working with a lot of data stuff. And it always comes back to the same thing for me. From a clinical perspective, how do clinicians make decisions? It's largely a lot about data, isn't it? And sure, you will argue, some of it is gut feel. You look at a patient, you have to consider social factors and all that sort of stuff. But most clinicians will say, what's the creatinine level? How high is their A1C? A lot of it is around data. We have a lot of data to deal with. There's something called Miller's Law. How many people have heard of Miller's Law? Okay, so Miller's Law says that the average human being can process a certain number of things at the same time, and then they fall apart. They just can't really do it much. So any idea what that number is? How many things? Sorry? You know Miller's Law. Roughly 7 things. Plus or minus 2, exactly. So 7 things. Human beings are complex. Disease is complex. There are way more than 7 things going on with people. And we're expected to make decisions based on so many of these things that come in. So we definitely need help. So point 1 is a lot of the clinicians' decisions, whether they like it or not, is based on data. And I'll be the first to say we're not very good at it because we're humans. We don't process data nearly as well as a lot of computers do. But then you flip over to the second part of where's the future headed? How do we need this to look? And I look at some areas like the automobile industry, these self-driving car things, right? Yeah, sure, they're not perfect, but they're pretty impressive what they can do right now. If you really think about it, all it is a car with cameras and sensors. That's really all it is, right? But what they've been able to do is they've been able to figure out how you rapidly get all of that data, put it into a central place, process it in a disciplined way, and make decisions within a blink of an eye. That's magic. So they have a discipline there of getting the right data, the right quality, the right way to analyze it very quickly to make decisions. If you think about it, a human being is a source of data. That's kind of like your self-driving car, right? When you go to a hospital or you go to a clinic, there are lab values, there's urine samples, there's heart rates, there's temperature. All that data is going in. The problem we have is I don't think we've been as disciplined to actually bring that data into a central place, to process it in an intelligent way to really make decisions that are effective. And I think that's probably where we need to head.
Great, thanks very much for that context. So as I was saying, we wanted to get the discussion going. Actually, I was already taking notes. I do promise there won't be an exam at the end of this, or maybe there will. We have a couple questions to get things going. So what I'm going to do is read out the prepared question for all of you, and then that way I'm just going to go through our panel here to see for them to basically we'll take off the gloves and start fighting over it, right? No, not quite. Yeah, so we'll keep it under control here. So the first question we have to frame because we've touched on a lot of issues in that introduction there. So to start framing some things, here's the first question. What are the benefits and trade-offs of sharing and linking personal health information? And to help us focus on that, what has been done elsewhere we can learn from, and who owns this information? So that's a three-part question. So how do you want to dive into that one? Ohad.
I mean, I'll start from the end. I've already established my position. You own the data. There's no question about that, right? And again, getting into that mindset of thinking yourself as a consumer of healthcare services, where the data is one of your forms of currency, and I'll unpack that in a minute, is part of the transformational change that we have to start, because actually the systems won't change. It's us as consumers, as individuals, that will ultimately change the system. The current picture of access to healthcare data as an individual is not a pretty one, right? You could be treated at St. Mike's Hospital, where Mohammed works, and you could go across the street to UHN, and in order to get your imaging data, they would have to tape it to your chest, or make you pay $15 to burn it on a CD, or print it out, or maybe even on a handwritten note in some cases, right? And if you want to share that data with your family, with your friends, with the people that are helping to care for you, maybe with actually one of the apps that you downloaded that could actually improve your behavior if it only had access to your record, that would be very powerful. But that's not happening today. Let's try to paint a different picture. Let's try to paint a picture where access to data is driven by consent, by your choice with whom to share it, that we can really democratize that data. And I'll give you an example. I love where you went with transportation. I think it's a fascinating industry, and I think we can learn a lot about how transportation uses data. Has anyone heard of a company called Waze? Great, so it's a lot of people here use it. It's a traffic navigation app that builds a real-time picture of the traffic based on reported data from the users, right? How fast am I going? Did I stop at the light? Did I turn left? Did I turn right? A lot of that's automated. Some of that is also self-reported. Did I see a traffic cop? And they build a real-time picture of that to identify the best form of interventions, of helping you to get from point A to point B. Now, what's fascinating is that all the users on the Waze network are all sharing data in a co-opetition model, right? They're collaborating to build the most comprehensive picture of the transportation data that's available to them, but they're also competing, right? They're in a rush to get to point A or to point B. But they've been able to establish kind of an equilibrium where you're sharing that data to create options for real-time interventions, right? To find the best possible route. The traffic is here. The loggers are coming from Merritt to Vancouver. Don't take Seymour Street. That's where they're headed. And so let's jump to healthcare for a minute. Imagine if you were able to decide when to share your healthcare data, of course de-identified, of course anonymized, but to share the data and to build a real-time map of the population health of your community, of your environment, right? And based on that, to suggest real-time interventions on how to deal with the specific condition that you have. Now, of course, it's going to have to come with a trade-off. You're going to have to give your data in order to get something in return. I would say, though, that in the digital environment, we're pretty well conditioned to that, right? I mean, I look at our relationship with Google, right? We let Google trawl through our email, our pictures, our search history, because in return, we get an email service, we get storage, we get free searches to get the products that we want or need, right? So that type of relationship with the data where you're giving something up, you're giving up something of your privacy. Yes, it's de-identified, but I think that's a transformation that we have to overcome with our relationship to our healthcare data, and to recognize that there's something in return. And back to the point I made earlier, that data is a currency, and you can use it if you recognize that you own it. And again, it's incumbent on us, and I'm speaking here the role of industry, to be able to facilitate that, to establish the right mechanisms for privacy and consent for you to be able to have choice.
Good context on it. So Fiona, over to you in terms of what you view are some of the benefits and trade-offs from your perspective of sharing and linking personal health information. What has been done elsewhere that we can learn from, and who owns this information?
Yeah, I first just have to say on a personal note, I use Google Maps to get here in time just barely because of traffic issues. It rerouted me. So I'm more than happy to share my position on my phone so that I can take the advantage of that. With infectious disease data, though, it's interesting because there's a whole other level that occurs of there's literally another organism in you. And so that becomes who owns that data? And this becomes an issue because what ends up happening is somebody will say, take your microbe from you that you had an infectious disease. They will sequence the genome and get the DNA code of that bacteria. And that data actually is like a fingerprint of that particular microbe. And if you compare them all, then you can see which ones are related, more closely related, and you can actually track how a bug, because every time it divides and makes new daughter cells, or I guess we shouldn't call them daughter cells anymore. You make them. You basically end up with this situation where they slightly evolve, and so this sort of similarity between them you can use literally to make a map of how a disease is spreading. So very valuable sharing that data, but that data tends to be considered to be owned by the person who sequenced it, by the clinician. And this becomes a problem because people want to sort of share this data more, and it comes down to there's a lot of literally social science barriers to people not being willing to share data, people being afraid of sharing data. Now, the analogy of banking is very good, that there's concerns that maybe data will be misused, but you could argue that you own your own banking data, and yes, people will make mistakes with how they decide to invest, but in the end, it's sort of their responsibility, and you can put checks and balances in. But I do want to address the issue that I think you can be smart about the ways you share data, and there's approaches that can be used that can be very effective. And then the last thing I want to bring up is just this concept that that all of this data sharing often has economic benefits that you don't even realize. Like, for example, there was this E. coli outbreak that had happened in some salads. It was clear that people were getting sick from some salads. Over 50 people died in Europe in this very short time frame, and they didn't know the source because they didn't have good tracking. But the impact was there was all these vegetables left rotting in the fields because they didn't know which vegetable it was. 210 euros in compensation had to be given to those farmers. I mean, these are significant impacts that are occurring. So there's a lot of other impacts that are sort of maybe 1 degree of separation away from a direct impact of not sharing data.
Interesting perspective on that one. Mohammed, initial thoughts?
Yeah, I think my colleagues have been quite eloquent. I agree completely. Who owns the data? It's you. It's us. We really own the data, don't we? When we look at the pros and cons and what data can do, going on the infectious disease example, what if we could predict the next big pandemic? Would that be fairly useful? Probably be pretty helpful, right? There's a company in Blue Dot that's trying to do exactly that. And they've actually had some success in modeling other outbreaks and conditions. What they've done, something very smart. They've actually grabbed so much airline data, practically all the airlines, and figured out where people travel and how, and looked at infectious disease outbreaks and patterns, climate, mosquito breeding patterns, all sorts of that data go in, and it actually helps model where we think the next big pandemic is going to be. That'd be very useful. What if I told you that we can use data in a hospital that will predict 24 to 48 hours in advance when a patient is going to die or go to the ICU. And we can predict it at a level that not little, but way outperforms clinicians. Would that be helpful? Would you want that? So we'll be implementing that in a couple of months at St. Michael's Hospital as part of our data science team. Now, some people may look at it and say, well, wait a minute, you're using our data. Well, we are. We're using it to help you. And I think the risk here, though, is what if some of this data leaks? What if there's a celebrity who comes into our hospital and people get excited and people know that a celebrity is there and what conditions they have? That obviously, the risks are going to be there. And those things, I'm sure, will happen. When we kind of counterbalance, though, how many people can be helped with this data versus how many people would be affected by things like leaks? I would argue that, yes, we have to have some discipline there, but with the right parameters, we can achieve that balance of allowing access to the right individuals to do the right things and minimize that risk of the adverse outcomes such as leaks and affecting people's identities.
Some good context there, and putting it in the different perspective of the ownership. But this theme I've seen here is what we're already able to learn from other sectors. Because it's just that our data, well, I was going to first say our data is different, but it's actually not necessarily all that different, because we're able to use data from one sector and apply it to another sector, whether it be the weather data for even sports data for, okay, there was the Canucks lost, so you're going to predict that there's going to be a riot downtown or things like that, Well, yeah, But no, in that context too, I guess, and looking to the future, and one of the things raised, the different ways of using data, because we talked about the ownership of, imagine a world in which everyone owns their own personal health data. Perhaps elaborating on that a bit more in terms of other jurisdictions, like how is it done differently, say in not only in different parts of Canada, but even in different countries. Would anyone like to speak to that one?
I have a fantastic example. I just got back from Israel a week and a half ago. Super interesting country in terms of its health ecosystem. So first of all, they have an HMO model. So HMO means that the payer is also a provider. Here we have a single payer system, and that the providers are not directly affiliated to the payer, right? They're private entities, and they work in a fee-for-service model. Right, so essentially, there's a little bit of inherent tension in our system, because the providers at some level, their main driver is to get more and more people through the system. Right, they're kind of a little bit on a hamster wheel of getting the patients through the system. The payer's interest, right, is to measure outcomes, but they're not directly managing the cost, because the cost is being dispersed on a fee-for-service basis. In Israel, there's an HMO model, so again, the payer is the provider, which means they have significant incentives to invest in prevention. They have significant incentives to invest in data. So across the 4 HMOs in Israel, they have full electronic medical records for over 25 years now, and that means your entire longitudinal record. So that's your medical record information, your imaging data, your lab data, some information from allied health professionals. And just to your question, Fred, the amazing thing that is being done in Israel now is that this kind of massive wealth of data is being made available to startups through the hospital system. The hospitals are all owned by the government. And so startups can work directly on the data assets of the population of 9 million people, 25 years, full longitudinal record, as long as they're working on premise. And they have a licensing agreement that basically commits future royalties but not equity in the company, which is an amazing thing, because you're meeting an 18-person startup in Israel that is sitting on 9 million records. And so their capabilities from an AI standpoint, their capabilities of machine learning, natural language processing, to really further the utilization of data are so much further along than we have in almost any other jurisdiction. Compare that to Canada. We don't have one healthcare system, we have 10. Right? Every province and territory has its own healthcare system. So even where we do have automation, the provincial boundaries are preventing data to be proliferated and shared, and more so is the actual limitations on the data use rights. So I was really inspired to see what Israel is doing, and just such a progressive approach, and recognizing that data is a tremendous asset that's really driving both the economy there, but is getting to tremendous advances in medicine. So a lot of great ideas to take from that, and let's think about how can we apply that maybe in the smaller context here, perhaps not federally or nationally, but in a province, right? Could we work within the PHSA here in BC to provide de-identified access to innovators that, as long as they're working on data that is furthering the common good, and maybe providing future royalties to the government, they will receive much deeper access to patient records. So just an inspiring thought I wanted to put out there in terms of other jurisdictions using data very differently than we do here. Okay,
good examples there. Any other examples of other jurisdictions, things we can learn from? Fiona?
I will just mention one thing. The FDA in the U.S., that's the Food and Drug Administration, has implemented a really interesting approach for infectious disease outbreaks. Again, I'm mentioning that as one example, but of course a lot of these things are relevant to a lot of different kinds of data. But In that case, what they're doing is whenever there's a foodborne outbreak or foodborne disease somebody has, they're taking a culture, they're getting this DNA code from this bacteria, and they're posting it up on this website. It's de-identified, and it's just reflecting a region of the U.S., but there was a lot of concerns about this. There was a lot of concerns that companies would sue, like food production companies would sue if they were maybe mistakenly thought initially to be the source of an outbreak, and it turned out they were not the source. So they basically, but they decided to go ahead with it anyways, and you know what? The FDA has not been sued. The sky has not fallen, and it's actually been very effective in allowing little clusters of cases to be identified from across the country. And this has become really important because of another growing issue that's occurring, which was brought up, is the international nature of how our behavior is. We're tending to fly big distances. Our food is being produced and then distributed over the world. Your bananas are not growing in BC. But this is becoming a big issue because it means when you have a disease outbreak, things can spread very quickly. And regarding the issues of flights, it's actually flight paths are a better predictor than geographic distance when it comes to outbreaks of where they're going to spread. So I always show a map of all the flight paths and say, basically I think in a zombie outbreak I want to head north in BC if you look at those flight paths and not go to the New York eastern seaboard of the US. But the point is that I think there is some real challenges though with this identifiability, and I see that a lot in other data too, including this national child study where we're profiling 3,500 healthy kids across Canada, a lot of information about them, and we basically have to be very careful that we don't have too much data on them that can very much identify them. And I'd be happy to talk more about that issue of identifiability, because there's the issue of later, but is there the issue of, do we already not have so much information about us? Are we already not being identified in many ways that maybe in some ways we have to just accept that as part of this cost-benefit analysis for the benefits of sharing data?
Yeah, good points there, and I put that notion of identifiability there for us to come back to. So, Mohammed, just over to you for things elsewhere.
Yeah, sure. There are quite a few examples out there. Immediately what comes to mind are some of the neat activities that are going on in the U.S. Kaiser, for example, has been pretty progressive in this space and implemented some pretty neat things. Intermountain Healthcare in Salt Lake City in Utah, phenomenal data culture there. They're probably the most rooted in using data in healthcare in the country. But I'm going to go maybe take a little bit of a different route, and I'm going to go there and bring up Google and the NHS in the UK, and how there are some major concerns by the public around how there could be potential private-public partnerships around data and analytics. Some of it is, I think, not well-founded, but others are. You can imagine, Google has incredible horsepower in the data and analytics space, and some would argue they're the best people to go at partnership with the NHS. But of course, there's a lot of issues around privacy and confidentiality, and that didn't end well, I guess you could say, in the UK. So a lot of complexities there. Maybe one other point I'll raise is why are people getting a little bit concerned around a lot of people accessing data? And I do have a few concerns. The primary one, not to belabor the point, is that I think we have to take a very careful approach to analytics when it comes to healthcare, specifically healthcare, because it's one of those sectors that will directly impact people. So what I worry about is that we have people who are not very experienced, who are playing and coming up with solutions that may actually harm people rather than help. And we have examples of these. If you want, I can expand briefly on it. Is that okay?
Briefly, yes. Yeah, please. Yeah.
So maybe I'll give one example. There was a trial that was done, I believe it was in the Netherlands, where the concept was actually quite simple. The issue is a febrile urinary tract infection. So the concept here is somebody comes in with pain in the back, with a bit of a fever. And as a clinician in the emergency department, you have two options. One is you admit that patient into the hospital and you observe them, and obviously give them antibiotics if they need it. The second is to send them home on antibiotics. So what a research group did was they said, well, why don't we create a risk prediction tool? So we'll create a tool that will actually be able to tell you if the patient should go home or if they should be admitted. And what they did was they randomized about 35 different groups to use the tool or not use the tool. And what they found was that in the arm that used the tool, compared to the arm that did not use the tool, the admission rate was substantially lower. But what they found was that the number of patients who came back with pretty significant problems increased fourfold. So the tool was actually harming patients. And there's several reasons for this. One is the tool was very poorly constructed. And the second, the implementation was actually quite poor. So I do worry that it's not as straightforward as we have data, we're going to help people and change the world. We do have to take a fairly careful approach to this.
Okay, no, appreciate those other examples. And while we're still on this theme and following up, and I have not forgotten about identifiability, I'm going to come back to that in a moment. Also, the notion which we've touched on a few times is the linking of data, bringing together data from different sources in that. We talked about whether Google has the data and that. And the one thing that just want to address to all of everybody on the stage is because it's now the source of a whole bunch of data from us, and you've all touched on it too, is our phones. Many people are now keeping track of their everything from it's not only keeping track of your location. People have health applications on it. It's keeping track of heart rate. It can be keeping track of heart rate, sleep patterns, mobility patterns, and things like that. So if we're taking a look for the future of healthcare rather than the future of insurance, determining based on your phone's behavior, what should your car insurance premiums be and what should your health insurance premiums be? And actually, same data could probably get a lot of insights in terms of this. I just wanted to talk about, because it can be used in such a range of areas, the kind of data that's on your phone. So thoughts about the mobile data or the personal data in terms of that and how that might fit into the equation. So feel free, whoever wants to speak to it first.
I'll take a crack at it. I mean, I think mobile data is incredibly powerful. There's so much data that goes in there. And, do people hit allow to every permission that they see on the phone? Some of you are shaking your head, but I bet a lot of you just say sure. Because I know I do. I mean, who's going to read through 10 pages of requirements, just agree? And maybe I shouldn't, but oftentimes I can't be bothered. When I have time, of course, I'll look through it a bit more carefully, but that's very rare. What I'm getting at is that a lot of us tend to agree to a lot of things we don't quite understand or read thoroughly, and it's collecting a ton of information. The power that's there is pretty ridiculously good. I'm pretty excited about it, actually. But of course, on the flip side, to your point, if there is too much freedom there and the insurance company gets a hold of it, well, that's probably not going to make a lot of people happy. So I think it's a matter of stepping back and saying what really should be allowed and what shouldn't be allowed. Why is it that I think previously on the Android phones, and maybe the iPhones as well, it wasn't you could choose what you agree to. It was just a whole bunch of things you just agreed, period. But now I think they're getting a bit better in terms of defining that a bit. It's going to evolve. And I think to Ohad's point earlier, it's about giving us decisions on what we want to share and what we don't want to share. And so I would say we can paint, you're the big bad insurance company, or you're big bad Google or Apple or whoever, but I would turn it around and say, well, we're agreeing to it. I think we're just as much at fault. And if we have issues, they should be raised. There should be a public forum to discuss this. I think we'll get there eventually. It's an evolution.
And sorry, Fiona, you go first.
I was just going to add a comment and a follow-up that, it's interesting, this issue, because, the BC Privacy Commissioner or something just came out today with some recommendations after reviewing these 22 practices and finding there was cases where, they were not providing good protection of data. But what I see is this disconnect, actually, of people sometimes worrying about data privacy in certain ways that maybe aren't actually going to be a big risk. And then there's other things that they don't realize is a big risk to them for privacy because of this lack of understanding of what they're getting into. And so I just like to raise the point that I think also education is going to become really important, and we actually need to train. We've got this, I've got kids who are 13 and 16 now, so they're going through this new BC curriculum. Very impressed with it. It does a lot more on critical thinking skills and a lot of soft skills and social skills that I think are really important, particularly for people like in my family where we're all sort of a bit computer geeky and we need some social, learn some social graces. But you know, it's been really, really good. But I think we're lacking a little bit in these issues of touching on privacy and educating about data and data use. They're learning about critical thinking skills, but I think there's more we could do in that area.
Good interjection there, and then Ohad, over to you.
If just to add something I fully agree with what you said, Mohammed. That there's good and bad in it, and I think it's about finding the right tool for the right job. Right? I mean, just like go back to the banking examples, there's things that mobility and the use of data on my mobile phone is amazing, like sending a $100 Interact transfer to Fred, right? And many of you are too young to remember, to do something like that, you would have to go to a physical branch. I mean, I'm sure a lot of people here don't have a banker. Has anyone here never been inside of a bank? No, not yet. We're getting there. Yeah, we got one. That's a classic healthcare job. That's a perfect fit. When I sign up for my 25-year mortgage on my house that I live in with my family, I'm probably going to meet the banker in person, right? I'm probably not going to rely on data on my mobile device to help me make a more informed choice. I'm going to need that high-touch approach. And so I think like healthcare is such a good example. I mean, you look at virtual care. Right. I mean, I asked about banking. Has anyone here ever been to see a doctor? Yeah. Has anyone ever been to a doctor's office? Yeah. So again, some of you are younger, but keep your hand up if the last time you went to see a doctor, your experience was by and large the same experience you had when you first went to see a doctor as a child. Everyone's hand is still up. If your hand's not up, you're lying because it hasn't changed. Right? And like I look at something like virtual care to think there's so many healthcare jobs that could actually radically change the way I interact with my primary care, like renewing a prescription. I just had to get a prescription for my orthotics. And I had to go and do the usual process, like wait in line, sign the paper form. I filled this form before. It looks really familiar. Have you been there before? Right? The waiting room all looks the same. Right? So again, great example where like healthcare data that's available through virtual care can solve many of those jobs, and many of them it won't. And I also want to say I think there's great advances in actually leveraging the data that's on your phone as a therapeutic. There's this emerging field of digital therapeutics, which are basically the equivalent of medications, of drug therapies that are available digitally. They're especially prevalent now in the field of mental health. Cognitive behavioral therapy, right? So being that partner to you, being able to better triage and diagnose and treat mental illness. Again, not for every case. It's the right tool for the right job, but for mild to moderate cases, great outcomes. Diabetes is an amazing example. Digital therapeutics for diabetes are now reimbursable by the Centers for Medicare and Medicare in the US. Right? So that's actually the equivalent of a drug, and it's getting better outcomes than many type 2 diabetes drugs in terms of behavioral change, reminding you at the right intervention at the right time to stand up, to walk, to eat better, to act differently, to have a podiatry exam or an eye exam to help diagnose your diabetes or prevent it. So I think there's a lot of untapped power, but again, let's find the right tool for the right job with the right level of information and consent to what we're doing with this data.
Good insights there. Thanks very much. And before we wrap up this first round of the questions, I wanted to come back to our identifiability issue that Fiona had raised there. And Fiona, do you want to speak to it briefly before we go on to the next part of the questions?
Yeah, it's just that, there's different kinds of identifiability that come up, if somebody has an infectious disease and they're at a certain area where, the only person who's building is in that area is a president, for example, or a prime minister, you basically have identifiability a bit more there and a bit of a risk. But it's interesting that that there's technologies now for ways to sort of massage data a little bit, I've used this iNaturalist app, which is a really cool app if you don't know it, for identifying a plant or an animal. You take a picture and you post it, and it does this AI and tries to identify it. If you try to take a picture of your kid, it even says it's a human. I was really impressed with that.
Hopefully.
But yeah, it did. Yeah, it did confirm. My kids were impressed that it confirmed I was human. But basically, the idea though is I can opt to either have my specific location and tag that I saw this interesting plant or bird or whatever in this one location, or I can have this data be manipulated so that it shows the general region I'm in. And but the thing is, that wasn't the default, so I had to know that default. So again, it's about the issues of becoming aware and educated. I also just want to touch on one other thing, if I can. We really do have a bit of an issue with this. We come up with an app for something, and then there's sort of worries, of course, like you brought up, these concerns about things being done. But we already have a bad system. I am already a cyborg. I use this as this is connected to me. I need this to know where I'm supposed to go in the day, right? And so I am already using this to Google if something goes wrong with me or my child, to try to help diagnose what I should and figure out what I should do. So we do have to come up with something better than the people Googling a particular disease symptom and trying to come up with something and then worrying they have a fatal cancer. So it's really, but I think we can do this. I think it's possible. I think we have to be very careful. What I do is, a lot of the tool development I do from bioinformatics, I make things that are basically as precise as I can, so I know I'm going to make the right call when I make it, but I only make that call when I can. I sort of bring up the sensitivity and the ability to identify things better as I can make it better in that sense. But there's different uses. There's some cases where you want to identify every possible case and not miss anything, so you want to be really sensitive, and then you want to try to bring up precision as you can improve it. So there's a lot of issues to tackle, but I think it's very doable, and we have to do it now because already we've got mismanagement of data occurring just through people Googling on their phones.
Yeah. Okay, just to wrap up that notion of identifiability, do either of you two want to speak to that briefly?
I guess identifiability, it's really tricky because there's you can de-identify data and you can anonymize data, and then there's all sorts of other terms that go in there. And the more data you have on a person, the easier it is to be able to identify them, right? So I know back in the olden days, so this is maybe about 20 years ago, so a lot of you are quite young, we had this whole discussion around what is de-identification. Well, back then we would say, well, all right, strip out the patient's birth date and their name. And I think that's about it. And so then people said, well, we probably need to strip out more. Okay, well, maybe we'll add a few more things in there. At what point then do you stop? Because there is this kind of really soft point around really making a data set anonymized versus de-identified, and then actually having value around that data as well. Because you can't take away a lot of this other rich stuff. And you'll never really get there, right? The more data we collect, you can strip out 20 of those variables out of a 100 variable data set. You can still identify them, I bet, if you really wanted to. Because you have discussions around, instead of the postal code, you do the forward sortation area, so the first 3 digits. Well, even if you give me the first 3 digits, if I know a patient has HIV and was hospitalized on this day, if I really tried hard enough, I'm going to know who that is. So I think it's a bit of an artificial argument in a lot of cases.
Great. Want to comment on it? Or great. Okay, so I think we've touched on a lot of things. I want to move to our second prepared question so that we can then go on to questions from the audience. And the second prepared question was on the business of genetic data. That kind of data is rapidly growing. How can companies balance innovation with privacy when it comes to precision health? So who would like to start on speaking with that one? Any preferences?
So I think there's a couple issues there, but really for genetic data, I just want you to realize that there's many different kinds of genetic data. There's the genetic data of your what you consider your body, but your body actually technically has about the same number of bacterial cells in your body as human cells, because the bacterial cells are really small and they're all packed in your gut. And so they often talk about a second genome project. There's not just the human genome and finding out our DNA code. There's also this other genome. So it's not a simple situation, but I do think, again, ideally the data is owned by you, and then you have access to that information. I think there is, though, this very interesting change that's occurring regarding different generations and how they view. Again, it comes back to this privacy and identifiability there's the impression I get from talking to some researchers more in the social sciences and ethics areas is that the issue of having your data be sort of more public or shared is less of a concern by those who are who are younger, who have had so much of their data already open anyways and have not seen a lot of big adverse events as a result of that, whereas the people who are older will tend to have very big concerns about it. But it does come back to, I have to say, this issue of appropriate use, right, and how it can be misappropriated. But I do love the banking issue, again, because people are given access to their data, and yes, they can make mistakes, but that's really their responsibility and their mistakes.
Yeah. Maybe to add another perspective on precision medicine and personalized health, I think it's interesting because it creates an inherent tension between like highly personalized data, right? Genomic data is all about your individual genetic makeup, but in order for any of that data to be valid, it has to be validated against the population, right? So there's kind of that inherent tension between like highly personalized versus extracting it and expanding it to population health analytics. I mean, if I look at something like pharmacogenomics, it's a good example, right? It's all about personalizing. Pharmacogenomics is basically the field of tailoring your drug therapy to your individual genetic makeup, right? We all have a unique genetic makeup, unique metabolic makeup, right? So we respond different to medication. And a dose that works for you might not work for me, and maybe even a different kind of medication that is very effective for one patient won't be effective for the other, right? So again, it's all about being able to test and to highly personalize the drug therapy based on that. But again, in order to do that, you need to be able to abstract to a much bigger picture of what are trends we're seeing. What are we identifying in the genomic makeup of humans, the correlation of that to disease and back to drugs. So I think that's kind of an interesting inherent relationship. I think as health continues to evolve, it's going to become more and more personal. And again, we already talked about the fact that our phones, and I'm sitting next to a cyborg, our phones are very personal to us, right? I mean, they're actually like reflection of kind of our identity or our knowledge or our behavior, and they know so much about us, right? So like that relationship with personalization, that's very much a big trend in healthcare. And we will need to establish very strong connectivity as well as the ethics and privacy around that to be able to effectively share that data to make it highly usable. And again, back to pharmacogenetic information, right? If we don't share that data, then it won't be useful at the point of care for the prescribing physician or the pharmacist who's dispensing the medication and may realize there could be an adverse drug reaction based on what you were prescribed given your individual genetic makeup.
Okay. Mohammed.
So I'm not going to comment too much because I can barely pronounce genomics, and I understand that's what really, really smart people do. But I will say that that's probably the most intimate, sensitive data that you can have on an individual, right? But then I also step back and I think, okay, financial data, what do you think is more personal? What would you fear people knowing more about you, your health or your financial status? Who would say financial status? Who would say health? Okay, well, see, there you go. And yet, we're freely giving out a lot of information on our finances, and all the banking stuff is being done digitally. The other thing I would ask you is, how many people have the Amazon Alexa or the Google Homes in their homes? Do you think they're listening to us? I mean, they might be, right? But I have 4 of them in my home. They are fantastic. So again, it goes back to, we have a lot of personal private conversations in our home, and yet we're welcoming them to our very personal environments. And we have to step back and say, is health really that different? And I'm not saying this, it's okay, it's not. But what I am saying is that we have different standards for different things, I guess. And what it will boil down to is what I think Ohad had mentioned right at the beginning. It really should be about social dialogue and what we accept as a society. And I'm willing to bet that we'll be a little bit more liberal than most people really think.
Fred, if I could top up, an interesting angle also on precision medicine is how it's driven, before its healthcare applications, actually it's being driven, or genetics I'd say, are being driven by consumer behavior. I mean, by far the largest and most influential genetic companies are the ones that are investing in genealogy. Right? I mean, that's in general, that's become like an amazing domain in a very short time frame, right? I mean, you could not watch TV over the holidays last year without seeing an ad for 23andMe or Ancestry DNA, right? And I mean, that just raised a question for me also, like, when did DNA testing kits become stocking stuffers? I've always wondered, like, how that conversation goes with your wife or your spouse. Honey, here, I bought you a testing kit as a Christmas present to find out whether you're part Neanderthal. And so just very interesting to see that the consumer behavior is what's driving massive adoption of genetic testing that in the future will be used for healthcare purposes. Right now they're establishing massive databases, and sure, their panels are not as substantial. It's not a full genome sequence, yes, but a lot of healthcare data will be gleaned from consumer behavior. Again, back to my original point, that line between patient and consumer is rapidly blurring in our economy and in our society.
And if I could add another couple of comments about that, is I want you to appreciate that the precision health era is going to open up the doors to make actually deal with some inequities we've had. We've had a lot of medications derived based on certain populations of people, disproportionately not factoring in people with who are different backgrounds, disproportionately testing drugs on men because of worries of pregnant women. So we have this problem with a lot of drugs may work on 90% of people really well, but those 10% are getting disadvantaged because they have a different genetic background and they would react badly. And then there's other drugs that haven't been put on market because they might only help 50% of the people if you knew what their genetic background was. So I'm not saying this is something that's a big factor. I think in precision medicine there's a lot of other things we can do, but we have to remember that this might help actually with equalizing some of these issues we've had by allowing us to tailor medicines to somebody's genetic background and also bring out some more medicines that have traditionally not been used because they're a bit risky, because there's these adverse events in populations of people. If we can know who they are, we can basically use them more. And I guess I'll stop there.
Just one thing I'll add is just on that. Yeah, absolutely. I mean, I think there's a lot you can do. Like, for example, with these drug metabolisms, there's something in your liver called the P450 system, cytochrome 450, which some people actually have mutations there, so they don't metabolize the drugs as well. And we can identify a lot of these people. But at our hospital, and I think at many hospitals, if you don't want your data to be identified, you can actually approach the hospital and say, I don't want you to use my data in any of your activities. And there's a system there actually where they can be checked off and their data become virtually invisible. So it is about choice, and I think that's a healthy thing to do.
One thing I just want to raise in this last part before we open to the audience for questions is the notion, this is we're talking about genetic data, and we've talked about different aspects of it, whether that be the genetic data of humans or non-humans, or how much of this is non-human is the other aspect of it. But again, the different use of data, we've talked about genetic data for stocking stuffers, but like in terms of the most value people see is the genetic data for treatment, like we've just been talking about for there. But the notion of genetic data for public safety is one thing. When you're taking a look at things, okay, because of certain things that ties in, with the non-human genetic data, but also then where did you draw the line with, when the genetic data being used by the policing agency to find people that might be, this is the minority report kind of approach. So anybody want to speak to that kind of AI-ish kind of stuff before we open it up for general questions?
I'll just do a personal anecdote that I found. I did the 23andMe stocking stuffer. I did do that. I did.
As a gift, or was it given?
I gave it to my parents, who they'd gotten a lot of stuff. I didn't know what to get them, and I said, you know what? What do you say we do this? And knowing full well this is opening up a can of worms, but I knew this, and so I felt okay with it, and we talked about it. But then I didn't appreciate at the time how much it would open up this can of worms of then worrying about my children and what they might inherit, right? And so then I had to say, well, do I want to do the 23andMe on my children? But the consent for children, it's hilarious, that you're supposed to read this thing that they don't understand, so there's a lot of issues regarding with the genetic information, even about safety, about just identifying the one person can identify all these relatives associated with them. It can reveal things about families, about relatives you didn't realize you have. We have a sort of unrelated relative who discovered that they had a relative that they didn't know they had, and but this issue of identifying sort of somebody in a murder case, I think is just illustrative of this identifiability. And I think we have to realize that the cat's sort of out of the bag a little bit because of the sheer breadth of information you can get on relatives, and extended family that goes out pretty far. Your family can not just be your grandparents and great-grandparents, but just your whole genetic background of a lineage of people from northern Scotland, for example.
And they've never had a data breach, right, in 23andMe? Right, yeah, good. Never will. Anybody other comments on this one? Okay, so now is the great time where we get to open it up to the audience for some questions. So we have some mics at the back. So question number 1, question number 2 at the very back there, and question number 3 in the white shirt there. Then we'll go for the next round of questions. So number 1, okay, right there. So if you just hold up your hand, they'll pass a mic to you there. And if you just want to say your concise question, and if you want it for all the panelists or one panelist, and we'll let other people chime in on it. So.
Yeah, it's for all. Great discussion. Thank you for your perspectives. I just had a question about data quality. And it sounds like kind of an assumption underlying the comments is that all the data being used is perfect and clean. And as we know, it's not. People enter data with their pen on a flip chart. They make mistakes. Doctor's handwriting is not perfect, but getting better. So I just wonder if you have comments, thoughts about garbage in, garbage out. If life-saving or life-threatening data depends on the quality of the data itself and the cleanliness. What are your thoughts about that issue? Thank you.
Great question. So whoever wants to take it first, and we can pass the mic on to the next person.
I'm just going to bring up one item that also addresses this. Has things changed in the physician's office? It has changed for me, because one of the things I do now is I used to go to my physician, they would do the scrawly writing thing, and it would be actually really hard to see what this prescription was for. But my doctor now types it out and prints out this prescription that's all printed out with good text, and it's much clearer. And I've never had the pharmacist have to phone the doctor like they've had in the past to check. But I do absolutely agree. This is one reason why, in the tools we've developed, we err in the side of having a lot of checks and cross-checks to make sure that that we flag any possible issues. But I really worry about this. This is, like you say, garbage in, garbage out is absolutely a key problem. And we need to make sure that quality is up there if we're going to do any, particularly if you start doing these large-scale analyses, because it gets amplified.
I guess you're raising such a critical issue, and that's another big concern around how we approach data analytics in healthcare. I know at our hospital, for example, we spent about 3.5 years because when we were setting up our shop, our vision was, sure, we'll get a bunch of data scientists, we'll grab our data, and we'll work with clinicians, and everything will be really great. And of course, when we looked at the data infrastructure and the data quality, we put a halt on that, and we said, we can't do this because our data are a mess. So we literally spent about 3.5 years understanding why we have 4 sources of allergy data and why some don't agree with each other, and maybe if we linked here and here, it would actually make a little bit more sense. But let's ask the allergist around what makes sense, and tons of time spent on that to get that right. So I would completely agree with you. I think we've got to make sure that we work with good quality data. I would take that even one step further, though, is that I don't think a lot of us have a good understanding of bias and confounding. And even if you have good quality data, do you have enough of the right data to do your analyses well? And the case example here is an old classic one, hormone replacement therapy. In the 80s, we had these studies come out saying that in postmenopausal women, hormone replacement therapy, that wasn't actually the study, that hormone replacement therapy would actually decrease your risk of cardiovascular events by about half. And the studies were quite biased. We didn't know that at the time, but millions of women postmenopausal were then put on hormone replacement therapy. Of course, 20 years later, we realized it actually increases your risk of heart attacks, and I'm sure a lot of people died from it. The data that went in was reasonably clean, it was pretty good, but it didn't have all the other types of data, because what people didn't realize is, at the time, it was likely that more educated women actually sought better treatments, and the clinicians would put them on the hormone replacement therapy thinking that this was the right thing to do. And it wasn't the hormone replacement therapy, it was because they were more educated, better lifestyle, all that sort of stuff. And that's where I think we failed people. So it's going to be about the quality, the quantity, and the right approach from the data.
Really good example. Ohad, you want?
I don't have much to add. I would say, though, that technology has also an important role to play in the quality of data, because at the end of the day, the more data you have, the more checks and balances you can apply, right? If you've seen 3 exams and you come across a 4th one and you're like, well, it doesn't look right, but you've only got 3 samples to compare it to. Whereas if in your AI lab, you've seen 3 billion exams of that type, then it's, your statistical significance is very different, right? So, I think, yes, data, like garbage in, garbage out is 100% true, but I would say that overall the prevailing trend will be more data actually will lead to more accuracy. And a lot of the examples you gave were, data always existed, whether it's analog, a scribble is a piece of data, right? That data was much less accurate than being able to track that data and record it inside an electronic medical record.
Okay, great. Very good question. Thank you very much. Next question is at the back there.
Hi, thanks for a great discussion. As a clinician who wore a pager up until 3 years ago and currently still writes in a paper chart, I'm just wondering how you see AI and big data working alongside clinicians and how that evolves or disappears for a very worried clinician.
Ooh, I like that question.
Yeah, maybe I can take a first crack at that. So my background before working for TELUS was medical imaging. And medical imaging is actually the first domain that's massively applied AI, because medical imaging is by and large kind of highly nuanced pixel data, and kind of the idea is that machine can do a better job, or can do maybe an equally good job of being able to identify those nuances to to call out whether it's a nodule, to measure it, right, and to ultimately perform a diagnosis. So radiologists have been worried about AI for a long time in terms of like career progression and the viability of their profession. But I read a great quote from the head of radiology at Stanford, who said, AI will not replace radiologists. Radiologists that use AI will replace radiologists that don't use AI. And I mean, that to me is kind of the crux of it. I fully believe, and I see that in everything I do with digital health, is that marriage of high tech and high touch is so profound. It's, medicine will never fully be machine oriented, right? There's a human component there. And finding that right balance is going to take time. There's ethics pieces to that as well. There's technology. There's the capability of the creativity of the human brain versus the machine. And so I think that the medical community, and I really encourage them to continue to embrace the use of artificial intelligence from a place of confidence of knowing they have an irreplaceable role in our lives, but that the role that machines will play will actually make them much better at what they do.
Great context. Who wants to speak next?
Yeah, I agree completely with those comments. We actually have, our team has over 25 projects that we work on at any one point in time, and one of them is actually in medical imaging. And it's being led by a radiologist working with some of our data scientists. And I got to say, I think it will make people much more efficient. I don't think you have to worry about not having a job. It's just doing things a little bit differently, right? And how much time do you spend in front of the EMR trying to...
Some systems don't link. I have to look in other places for data. It's fraught with issues right now.
Awful.
I am desperate to get engaged and our systems to change. You talk about provincially things are different. It's like an absolute nightmare sometimes to navigate through to try and deliver the best care to our patients.
Completely. And I think we're in that transition phase, and we will be for a little while in terms of getting that right. And I think I feel badly for the clinicians now because you're caught in the middle of it, and this isn't going to change overnight. It's going to take a bit of time. But what I'm seeing and where I see the future heading is it's going to be so much worth the pain. We have all these innovations that are coming out, like Babylon, for example, from TELUS. That's kind of needed. That's where virtual care, that's the direction that it's going. So it's going to change a bit of workflow. Is the future going to be your patient coming to your hospital and you writing things on paper? It may not be as much of that. It may be a virtual consult. And we're seeing a bit of that already. But is it also going to be you dealing with a messy EMR? The future may be having like a Google Home type device in your office listening and transcribing for you. I think all of this will come. And right now it's a bit of a tough time, but I would say be adaptive. It'll get better.
Fiona, anything you would like to add? No. Great. Very nice question. Thank you very much. We had question 3 over here.
Hi, yes, thank you for your insight. I'm hoping you can speak to my concern. I'm just a little bit worried that we're having this conversation in a bit of a vacuum without context of sort of politics or greater social inequities. And we were talking a lot about choice and freedom, but I'm wondering, whose responsibility is it to educate people about data? So that said, my question is, or what I'm hoping you can speak to, is a bit about industry transparency and data governance frameworks.
Okay.
Yeah, I'll just add the point that I'm really keen on getting education starting early. I really like the idea, right in kindergarten, people learning things so that our public education system can start to address some issues early. I do strongly believe, though, we have to be very careful with how we're designing things to make sure that there's equitable access to all of these new approaches and new technologies. It's going to become more and more important as we become more empowered, as the individual becomes empowered. We don't want it to be that the we that becomes more empowered is a subset of we, right? So I think that is I really thank you for raising that, because I think this is a very important point that we always have to step back and realize that we shouldn't just make it for this one mass of people that we think the vast majority is, that there's a lot of other people that often have very significant health care issues that we have to make sure don't get lost in the shuffle.
Great. Either of the two you want to comment?
Yeah, that's such a great question. So important. And I have to say, I don't think anybody has any idea, to be honest. Realistically. Because, when we're looking at simple things not simple things, it's very complicated, data governance. I can't tell you how few healthcare organizations that actually have good data governance processes and have actually worked this out. Because we've been struggling with it, and we've tried to look at quite a few places, hospitals, primary care clinics, all sorts of groups that actually are saying they have data governance, but when you actually dig in, they don't. And a lot of us have to create our own. And to your point, should that be right? Is that the right thing to do? Should it not be a broader issue than that? And I would argue absolutely it should be. But I don't think anybody's really figured out who owns it yet. And I really hope they do. So I would be the first to say, I wish I had a better answer to your question. I don't.
Yeah, maybe I could top up with the industry perspective. I truly think it's a fantastic question, and there isn't one single answer. I think the way we'll get there, though, is by having industry at the table, because I think historically, when kind of in our single-payer system, we're thinking, well, the government should be the great leveler and decide how to roll this out. And I really look at it as a nexus of industry, academia, and government working together. And I think, increasingly we'll see industry play a larger role in healthcare delivery, in the relationship that we have with the healthcare system. That doesn't take anything away from the ethos that we have of healthcare being public. But I think having industry at the table and recognizing that in many ways technology can be the great leveler, right? It actually does increase accessibility. And of course it has its own inequities buried into it, but I would say in comparison to the alternative, technology is actually enabling far greater access to healthcare services and to healthcare data than ever before. It doesn't solve everything you talked about education, about governance, but I think it's going to have to come from a coalition that will get us there.
Great. Very nice question. Thanks very much. So this section, I haven't taken a question from this section yet. Any volunteers from this section? Too many volunteers from this section. Okay, at the back, because you were closest to the mic. That was the decision.
Hi. Thank you very much. And my question is about choice. So it looks like it's a normal thing to leave people choice to share data or not. But what if nobody chooses to share data? We will not have any data to train the models, or we might create bias against more educated people or youngest people. So is it better in an extreme case, I mean extreme on purpose, just to force people to share data so all the models will be better and everybody will take advantage of all data? It's like taxes. Everybody pays a little share, and then for the community and for themselves.
Yeah. I think it's an interesting point you're raising. I mean, you're basically trying to say we should be sort of trying to err on the side of this sort of force. And you certainly, I do think, though, it's really important to have that education component of, if you share this data, there's this benefit, because that's what I've found. The people I've ever hit barriers with not wanting to share data, they sometimes just don't realize the benefits of doing it, and then they might reconsider. And so I think it's important that people have choice, but I think there's ways we can make it more obvious what the benefits are, to make it more that they would want to actually share that data.
Any other quick response? I'm going to try to get through as many questions as I can. So anybody else want to add on to that one?
Yeah, there's all sorts of models out there, like implied consent, informed consent, opt-out, opt-in, all those sorts of ways that people do things. And to your point, I think the critical thing is if you basically withdraw consent and there's enough of you withdrawing consent, I say your data is quite limited in what you can and can't do because of the bias issues. And to Fiona's point, my own sense is that I think as much as possible we should be encouraging as much use of data as possible and people actually buying in. But also I think the differentiator is going to be for what purpose. And that is, I think, well beyond this forum. We need ethicists and privacy experts to really drive that.
Okay, we're going into the rapid fire questions here. So going into this area here, right there at the question back right there. Quick question.
Thank you. I'll try to make it quick. Hi, everyone. My name is Roy Tresiba, and I deal with technology and information technology and data. There are two things that I wanted to throw at the table that probably can change.
One.
I think the two of them can help. I'm going to try to be brief. One of them, you were talking about cars more than individuals. And by having information from a car, you're able to manage the traffic or the congestion. So that could be one thing that can help us do the other thing that I was going to mention. We are thinking about identifiability and trying to deal with confidentiality and privacy because we are thinking of people. I think we should change the perspective and not think of people, but think of the thing or the sickness or the health. The same way we're doing it with the car. We are not thinking of the owner of the car to control the congestion. We can think of the car itself to control the congestion. So that can help us deal with confidentiality and have a different perspective. And the other thing that is attached to this one When we compare financial information and health information, financial information has value. You can steal my money by knowing my checking account, or you can try to get me into something by knowing that I have this much money. But by you removing that value and just focusing on the issue itself more than the person, you remove the value. So that can also help go through that information. So I'm just throwing some things into the table.
Okay, a few things thrown there, so feel free to unpack one of them. So, Ohad, any ones you want to comment on there?
You know, I'm still digesting.
Fiona?
Was there a question that you wanted to No, I think these were good points, but I don't know if I need to
address some of the issues of privacy and some of the issues of not having information, or big data being able, at the end, health is an outcome, it's not the origin.
Yeah.
So by trying to analyze the outcome, we are missing the big data, like climate, like food, like many other things that probably we do have access to. I'm just throwing some information for
And I do think this is I'll just bring up a couple of nuggets of food. Basically that, I think there is this issue that you're sort of touching on a bit, which is this idea of bringing other types of data is going to become really important. That is very open. We're with these 3,500 healthy kids. We're also bringing in all of this data, this environmental data that is basically allowing us to correlate some outcomes. But we are just focused on looking at the outcomes of a certain disease and then seeing the factors associated with that. And we can only do that if we have this collective data, right? But I do think we have to be careful. There's sometimes where there's the populace and the benefits to the populace, and then there's the benefits to the individual. It was more expensive to do giving the vaccine for HPV to both men and women, children in primary school. And so at first in BC, there was only the vaccine given to young girls, but then eventually it became cost effective to also vaccinate men as well. And so both boys and girls get vaccinated now. I paid, the $600 to get my son vaccinated before that was free, because I knew on the personal level he could benefit from not passing HPV to a loved one if he should contract it. And so I paid because I knew there was a personal benefit there versus a population benefit wasn't there.
Great, thanks. And we have time for a quick question there, and depending on how long the answer is, we might squeeze one more in. So over to you.
Quick question. People talked about how easy it is to share data when we have something in return. Given the transactional nature of the healthcare provision these days, everything is transactional. So information is collected in a transactional fashion. It's held in a vault. It's not shared with anyone. So people don't really get the benefit of where that data goes. So what if, the question I have is, how can we make the consumer a part of making a faster decision on their own health when they actually need that care through the service provider? Example, go to the ER and you speak with 5 people providing the same information over and over and again. So if you can speak to that.
Yeah, maybe I'll talk. I think you're absolutely right. I mean, there's so much redundancy. There's so many inefficiencies in healthcare, and I think this is where data analytics could help quite a bit, is to streamline that. Maybe I'll give one example. If we look at the diagnosis of breast cancer, right? The way it currently works is a woman comes in, they get a mammogram done. Wait, we got to look at it. So come in 2 days. We got to talk to you about something else. Now come in 2 weeks. And typically it's about a few days at least, a 2-week process for you to get a diagnosis. If we were to tell women that, actually, if we actually streamline this, we could give you a diagnosis the same day. That would be transactional. I think you would see a benefit there that you don't have to keep going back and forth. And I think we do a poor job at communicating this. If we were to tell you that we can use your data to actually see if you're in the hospital, if you're in trouble and you're going to die in the next 48 hours, we could probably help you earlier. That's a bit of a transaction again. So you're absolutely right. I just don't think we've really thought about it as well as we should have in that sort of a mindset.
Great answer.
Yeah, if I could throw another idea out there is, I think the financial incentives are just misaligned to make more productive use of the data. I mean, again, in a fee-for-service system, it's all transactional, right? You just got to get the patient in and out, right? But like if you could establish incentives that are value-driven, like fee for value, if you could reap the real benefits of investments you make in leveraging data to be proactive or to invest in prevention, then I think you would be much more prone to use it. And you could say at the highest level, yes, like the government of Canada, yes, it's fee for value. It's measured on the outcome and on the cost. But like each pocket of the healthcare system doesn't work that way. I think it's very interesting, like employers, for example. Employers cover almost 30% of all healthcare expenditures in the country, right? There's no national pharmacare program. Like employers are the ones that are paying for your drug coverage. They're paying for many of your allied health services. Employers are fee-for-value buyers, right? Employers invest in healthcare in order to get better productivity, to decrease absenteeism, to address presenteeism, to get higher engagement from their workforce. So like that's just an example of like a microcosm where you're seeing employers are investing much more. Again, virtual care. Employers are at the forefront of leveraging virtual care because they have a high ROI. We've introduced a virtual care product here in this country, and we're seeing that a very large number of consults through employers, a very large number of consults are occurring between 8 and 9:30 a.m. That's an amazing data point to just think about what that means to an employer because one of the first healthcare choices I have to make when I wake up with a sore throat or my kid is sick or my aging mom isn't feeling well is I have to decide, am I going into the office today? Or am I going to wait 4 hours at the clinic to deal with it? So if an employer believes for a nominal fee, I'll give virtual care to each of my employees and they can make the healthcare decision in the morning that could significantly improve productivity in that day, they're leveraging data to make a much more informed choice, and they're reaping the benefits of that, where, again, the public system isn't always there because of the fee-for-service model. So we really have to think about reimbursement reform. It's been tried in a few provinces. Ontario's may be going there now. But I think that is going to be the principal driver to your question of how data could be better leveraged.
Good insights. Fiona, any final comments on that? Great. Well, I know we have lots of questions still, and that's why we already have the food out here, so it allows you to interact with the panelists and interact with each other about other questions you might have. And I first want to start by thanking the panelists for their great insights and observations. And I would like to thank you, the audience, for your good questions. And I want to thank Tanya and her team for hosting this and getting this all working here. Thank you very much, Tanya. That's a great thing about being the scientific director at the Big Data Hub. We get to talk to people from different domains, and you even heard it today. We're drawing on things from finance, drawing on things from transportation, and seeing how they relate to things in health and medicine and the range of things. And you can see why we enjoy coming to work every day, because the joke I have, if you have data and you have a problem, come talk to us, so. And it means a lot of people come talk to us. So instead, or you can come talk to me, or you can talk to Avi at the back. He's there to also chat about the wonderful things we're doing at the Big Data Hub. I want to thank you all for joining and starting this discussion tonight. I'm looking forward to continuing the discussion during the reception here. I'm looking forward to seeing you at the upcoming Data Visionaries events. We're going to be having we were talking about our cell phones and being around. We're having a panel coming up on 5G soon. So, I think that's going to be a good one to come to as well and ask questions about the health apps running on those 5G networks. So, thanks very much, everyone, and enjoy the rest of your evening.